I remember what the question was. The question is about maintenance. How long on maintenance? How do you know when to stop maintenance? When should you start talking to your doctor about these decisions? And you need this.
So many unknowns. Currently, we consider maintenance therapy to be indefinite. And I know that this is a big question for all of you guys, because you're saying, well, I mean, I've got to be on Revlimid or some such drug for the rest of my life. I mean, come on. Not only is it expensive, but it causes all these toxicities with fatigue and diarrhea. And I think that, the data is one thing that we have in front of us. And so, I know that Emory does things a little bit differently than we might do here. But for right now, listen, it's not an attack. Just they're very proactive. But I think it's very clear, and Monty brought this point up, is that there's very likely patients who are able to stop early. And there's also patients who likely require ongoing maintenance therapy. And there's likely patients who require ongoing multi-drug maintenance therapy. And I think that these are all questions that we're trying to get at. Monty also brought up one of the trials, the SWOG S1803 trial, is asking the question of, okay, well, what happens if we stop maintenance therapy in some of our patients based upon on MRD status, so minimal residual disease? How much disease do you have left in the bone marrow? And I think that this is an area of ongoing research. And I will tell you that every single one of us across the board, even though there's the old saying, if you line up 10 myeloma physicians, in a line, they're all going to give you a different answer. I think that across the board, it's very clear that we want to figure out who we can stop maintenance therapy on. I just don't think that we have that data in front of us right now.
So, so that's a great answer. It's tough to build upon that. But when I look at the landscape of maintenance trials, and a lot of the data for maintenance, as I mentioned during my talk, comes from an era where we didn't have such good initial induction therapy. So I think that at some point it is worth revisiting. And I know that there are discussions going on. We probably will see trials in the future where you give people a finite amount of intensive therapy, be that 1 year or 2 years, and then you just stop treatment altogether after that and just see how people do. That is what I sort of envision like the future of myeloma treatment, hopefully, to look like. And that's sort of what patients want as well, right? Because if you're on treatment, you don't think of it as a cure, even if you don't have any disease. So these are really, really tough questions, and we don't yet have really good data to guide us. And I think, as Doug sort of pointed out, an individualized approach based on the data that we have and based on the patient's individual values and preferences is how at least I approach maintenance.
I'm not sure what the crack about Emory was, but I didn't say anything bad. Just to start that off. So I think, and we basically are doing what you both said, is that we personalize treatment in my own clinic, in that rare patient who has low risk disease and has a spectacular response. I don't give them any maintenance, and that's different after transplant, for instance. And this is contrasted with patients who have high risk disease, didn't get a great response. I put them on 2 or 3 drug maintenance. So personalizing for the patient and what they're both able and willing to tolerate is, I think, the message, honestly, from all 3 of us.
Actually, I'm actually going to go 2 more questions, because this other one was kind of related to that as well. Again, this is a patient who's in remission, has been on maintenance, but the doctor is pushing for a stem cell transplant. What are the patient's options if they do not elect a stem cell transplant and they have done stem cell collection?
Yeah, this is a real common thing. So you're in the midst, or you just completed induction therapy or initial treatment, and I'm talking to you, hey, now would be a reasonable time. Things are as good as I expect them to be in terms of patient's functional status. What do you think about transplant if I haven't talked about it before? And some patients are like my mom. If my mom had myeloma right now, I would say, hey, you can come into the hospital and get treatment. And she would have stopped me right there. She's like, electively go in the hospital? No, I don't electively go in the hospital. Certainly not for anything that could cause nausea. So that would be end of discussion. No discussion at all about transplant. So and what happens predominantly, what you read on the internet is, oh yeah, if I do transplant or don't do transplant, it's about the same thing. And in truth, that is weighted for what's published. And what's published is not what people live. What people live is that if you either, the people that are thinking I'm going to do transplant up front, they do transplant up front. And the people who say, I'm just going to collect, because this idea of transplant sounds crazy, that never changes and they never go on to transplant. So that's what happens most of the time. That data is not easy to find, because all the trials are about transplant early versus late. It's not transplant or no transplant. And so what I tell patients is that transplant provides them a 20% boost in overall survival. If you have a 3-year overall survival because you have high-risk disease, it's 20% of 3 years. If you have a 12-year overall survival, it's 20% of 12 years, which is a lot different. Either way, transplant boosts your survival about 20%. It's not going to cure the myeloma, but on average, it's going to prolong survival at significant cost to your quality of life, whether it's in the hospital, fatigue, energy, et cetera. So in my own practice, I tell patients this and say, are you really sure you want to collect stem cells? Because if you want to collect stem cells and store them, you're probably never going to undergo transplant anyway. And it may be increased risk of going through the collection and storage process that you don't need to take. This is probably very different than my colleagues.
So, yeah, he's going to polish this one off for sure. I'll just bring up one counterpoint to not collecting. I think that at least with our patients who are getting CAR T cell therapies, these are late line patients. Their bone marrow has been beat up. There is a risk of prolonged cytopenia, so low blood counts. And in some patients, they may benefit from having some of those stem cells as an insurance policy that's sitting in the freezer. And so in general, the discussion that I have with my patients is very similar to the one that Craig brought up. But I do think that if patients are electing to not undergo transplant early, I do recommend that we collect their stem cells and at least have that insurance policy in place.
All right. So, I am generally for upfront transplant. I'm going to start off by saying that, lest I be misinterpreted. I generally do agree with Craig that clinical trials are not representative of what happens in the day-to-day life. I will, however, say that, if you look at some of the recent trials, and if you look at all of the really good new treatments that we have for myeloma, the 4-drug induction that we're doing, there definitely are patients who are going to do really well. They're going to have prolonged remissions, and they may not need a transplant. And if somebody is really averse to the idea of chemotherapy, and we give them high quality, 4-drug induction therapy, and they get a really good response, and they may or may not collect stem cells. I do generally push for stem cell collection because I want to keep all doors open in the future. But you could make a point that things are only going to get better. So in the sense that, let's say somebody gets 4 drugs today and they get a remission and they don't do transplant, and they get a remission that lasts 4 years or 5 years. Well, it could be that by the time their disease comes back, we will have other things that are approved for first line, for first relapse, such as CAR T or bispecifics. That's very plausible. And then they'll get that. And then they'll get a very, very long time of remission with that. And they can live out their entire lives without ever being subjected to chemotherapy. Now, there are a lot of assumptions that I'm making here, but I do think that the current data does allow for some degree of individualization based on patients' values and preferences. And I think I weigh this differently based on standard risk versus high risk myeloma. There definitely is some, subsets of patients that I feel like very uncomfortable with them not undergoing transplant. But for some patients with standard risk myeloma, if they're averse to the idea, they understand their risks and benefits, they're willing to undergo collection, I think it's perfectly okay to collect stem cells and hold off on transplant upfront. But this is a very complicated discussion, and it requires hours with each individual patient and understanding their values and preferences. So I obviously cannot do justice to it in a short, 3-minute answer.
And and think about your questions, and I'll start, signal me after this question, please. Can cannabis be helpful to treat pain for patients in treatment or someone who is post-transplant and asymptomatic? Who wants to go there? Give it to the young man.
Just because I have long hair, I guess. We're making a lot of assumptions here.
Bow tie. It's the bow tie.
I guess long hair is okay. So the short answer to this is yes, that cannabis definitely can have a lot of pain relieving properties. I don't really, there's some people who will claim that cannabis has the cure for myeloma, and there's some people swear by it. I don't know if I believe that, but cannabis definitely can help control pain, and can definitely reduce dependency on other pain medications. And for some people, it works really well. So I am not opposed to patients trying cannabis to help and augment their pain control.
I said before, I used to have long hair. So I think that the disease itself and our treatments cause a lot of toxicity. And one of the most important things that we can do for you as patients is try to optimize your quality of life. And there's a lot of different ways that we can do that. I know that Christina talked about some alternative therapies and breathing, meditation, exercise, all these different things. So very important. One of the tools that we have now is THC, and it's been very effective for some patients. Other patients don't derive any benefit, but it's not just pain. It can be neuropathy, it can be nausea, it can increase appetite. So it has a place, especially for some patients. And now that we're able to prescribe it, I think it's something that's worth trying for some people.
Questions? We'll start here and then I'll go up there. Who'd like, and I'll hold the mic for you.
You all were talking about the transplants. The lady that was here earlier from Wisconsin, she was saying that the stem cells don't need to be perfectly healthy or whatever like that. And what was your thoughts on that? You're saying the way you're talking about it, it sort of inferred that the stem cells had to be perfect.
I don't remember you're talking about Dr. Calendar. That was here earlier. Yeah, I don't remember that statement. Yeah, I mean, I don't think I necessarily have a statement, only because I don't remember her saying so. I wonder if there was a question about myeloma stem cells or that piece of it. It was the CAR T. So I think it's a different concept. Yeah.
Oh, did you want to?
I guess the short answer to your question is that in the past, we've tried techniques to sort of purge, myeloma cells from the stem cells, and they haven't really been all that helpful. And generally speaking, if somebody is going to a transplant, we don't have to have eradicated, all cancer before taking them to a transplant. And sometimes efforts to eradicate cancer can delay and sometimes even take transplant off the table. So that's one problem that we do see in the community. So one message that I always like to spread is that, you should see a transplant doctor or a myeloma specialist, after pretty early on, within 3 to 4 cycles of therapy, so that we can talk about a transplant. Your disease does not have to be in a complete remission at the time of transplant. Just one point I really wanted to emphasize.
Good point.
Very good point. I'll run back there. I think it's probably easier to do it this way. And I'm going to hold the mic.
Thank you for your earlier discussion on precursors and smoldering. So you mentioned that you're excited about the clinical trials looking at genomics. Is that something that's available here in Utah or easily accessible for those trials?
I'll give that to a Utah doc.
So these genomic studies where they look at specific gene profile for patients with smoldering myeloma, they are not yet ready for commercial use. A lot of the good work that I'm personally aware of is, I know that some researchers at the University of Miami are doing some pretty innovative work and coming up with these assays. We do have a clinical trial here for smoldering myeloma. I don't think that clinical trial uses genomics or has a genomic component to it. So I don't personally think that I have that test available for my patient, but it's definitely something that we're excited about and will hopefully be used in the future.
So one thing that we are doing here, we have the Utah Population Database, which is an enormous resource. And one of our colleagues, Dr. Nikki Camp, has been doing a lot of work trying to identify germline or inherited mutations that may be associated with MGUS and other plasma cell dyscrasias. And so some of the work that we're doing when we're collecting samples from our patients as part of the biobanking is looking at that fundamental question. And so those are some of the active things that are happening, a little bit different than the question that you were asking, but yes, we have an enormous resource here in Utah and we're trying to tap into that.
This is a question we actually get a lot, and it's more of a speculative question. Do you foresee a day when there is a myeloma vaccine? That's going to be a short one.
Well, we've tried viruses. People are exploring vaccines. I think that the technology, I know enough about the technology to say yes or no. But I think it's an interesting idea. And I know that it continues to be explored. I don't know if you have any thoughts about that.
Nothing useful.
This is what David Avagon is working on. Is that right? There's a specialist in Boston named David Avagon who is really the pioneer in this, and he's pretty much the only one who's really super focused on it, as far as I know. One topic we haven't touched at all today is allogeneic transplant. So first one to answer, if you could explain what allogeneic transplant is to our audience. And secondly, at what point in the treatment and under what conditions do you recommend an allo transplant for relapsed refractory myeloma? And since you're shaking your head, I'm coming over here.
So autologous transplant is what most myeloma patients have heard of. They get high dose chemotherapy. They get some of their own stem cells right back to them. They head right back to the bone marrow and reconstitute or repopulate the marrow. The idea behind a donor transplant or allogeneic transplant is that you're replacing your immune system with somebody else's, completely repopulating it. So giving some chemotherapy, infusing somebody else's stem cells, and then suppressing your immune system so that their immune system can take over and ideally go where your immune system couldn't go and see your cancer cells as foreign and kill them. The idea sounds fabulous. And the it's associated with something that's not so fabulous, which is graft, which is the stem cells, versus host, which is you. And that's not ideal. That's when the stem cells not only realize that your cancer is foreign, but they also think of you as foreign and they attack you. It's your own civil war. And the problem with myeloma, which is different than with genomically simpler cancers like chronic myelogenous leukemia and somewhat acute leukemia, is that myeloma is very immunosuppressive. The cells in and of themselves, their existence is a fabulous immunosuppressant, which is why myeloma patients are always thought to have an infection because they often do. And so immunosuppressive, so they prevent a lot of the graft versus tumor effect, the new immune system attacking your myeloma cells, and they don't really stop the graft versus host. So in the majority of time, in most myeloma patients undergoing allogeneic transplant, you get all the pain and suffering of graft versus host disease for none of the benefits of graft versus tumor. So that's the deal with allogeneic transplants. The people who I would encourage to head towards allogeneic transplant are those patients where there's an interesting clinical trial investigating allogeneic transplant and changing something fundamental about that graft versus tumor, in some way amplifying the ability of the new immune system to attack the tumor. That would make me excited as a patient and a doctor, and would make me interested in referring that patient for donor transplant.
I love it. I love it. I feel like I'm back in high school. Not me. As a male Caucasian, this is the person asking the question. As a male Caucasian myself, what is your hospital doing to solve the problem of twice the number of African Americans being diagnosed, treated, and dying of myeloma than whites? Are there any advances in knowledge about genetic predisposition in our disease? And I know you all three are doing this, so who's going first?
Right. So this is an area of active investigation. So just to sort of recap the facts are that African Americans are twice more likely to get myeloma precursors. And then if they're getting, all myeloma originates from myeloma precursors. So African Americans, unfortunately, have a higher burden of myeloma. And there's a lot of work going on to try to understand why this happens. And a lot of the information that we have on, myeloma precursors comes from a predominantly white population. So the bulk of our studies have come from Minnesota, and, that original cohort by which we defined the natural history of MGUS was 97% white. So those facts may not apply to a diverse population. So I know that, in New York, there's a study called the PROMISE study going on, which is screening, those considered high risk for myeloma. So that includes African Americans, and patients are being screened. And there's a lot of translational research that's going on that will help us understand these myeloma precursor conditions better. And that's one step to fixing the problem, right? Like you don't want to end up diagnosing more pre-cancer, more cancer, and then not having access to therapeutics. So that is a completely separate issue that, we've been talking a lot about this. We're raising awareness, and we're hopefully starting to make progress. But we absolutely have a lot more work to do. But thankfully, a lot of work is being done to help understand these myeloma precursors in an African-American population, which is different than the original studies by which we learned about MGUS.
I think I'll just make one small point. I think that disparities is becoming an increasingly recognized issue, and racial disparities are on top of that list right now. And so a lot of the clinical trials are mandating that there are specific cohorts for say African-American patients. And so we're trying to understand how our drugs are working, not just, in all comers or in a predominantly Caucasian group, but also specifically in patients, in African-American patients. And so I think that there's increasingly amount of work being done. And I know that we're all focused on trying to identify the problems and trying to increase the amount of data that we have available so we can increase understanding. Want to say anything, Craig? No.
There was a question. Oh, boy. Now they come out as we get near the end. Oh, brother.
I've got a question about trials, and through the course of this workshop today, it's become evident that I think all of you have mentioned that there's a need for there's need for more trials to get more data to understand the disease. So my question is the reason that some of these trials aren't existing today or they aren't in the pipeline? I mean, is it an infrastructure issue? Is it a funding issue? Is it a what is it about the trials that, that's required to get out there and get this data?
I was sorry. I was trying to be an active listener. Thank you very much. So the good question about trials. So myeloma is 2% of all cancers, and about 3% of myeloma patients on average get access and enroll in a clinical trial. So there are more, turn 360 degrees, throw a dart in any direction, you're going to hit a problem with our clinical trial complex. Is it too much regulatory issues, not enough infrastructure, not enough funding, not enough patient advocacy or incorporating patients to advocate for proper trial design? There's nothing that's going well, or nothing that we can't improve on in the clinical trial sphere in myeloma. And because it's not as many patients, there are glaring problems that aren't potentially as difficult in breast cancer. Because breast cancer, there are thousands of patients that you can mobilize in a heartbeat, and same place, right? But fewer number of patients expose our clinical trial deficiencies. And so there's a lot of work to do to make things better.
So I generally agree with all of that. Just some more food for thought, and it's something that I think about a lot is, the bulk of funding for trials comes from industry. And there's very limited government funding for clinical trials. The government funds more basic research, which is incredibly important, but there's very limited funding for clinical trials. The priorities of industry are obviously, to help patients, but they're also to advance their products, right? And a lot of the times we end up with trials that may not answer questions of strategic value. So really important questions in the field of myeloma are like, what are the patients for which we can do less therapy, right? Like, what are the patients through which we can individualize therapy? But when industry makes a trial, with some exceptions, usually they are incentivized to do more therapy for longer periods of time, and cast a broad net. So these individualization and these smaller cohorts, they may not serve industry the best. So that's a problem that's not unique to myeloma. It's a problem unique to all clinical trials, that what is a strategic question may not align best with who is funding the clinical trials. And sometimes you get trials that don't answer questions of strategic value. And I kind of hinted that when I spoke about maintenance. It's a problem.
I will say that there's been, I think, a fundamental change in the clinical trial space in myeloma. And 20 years ago, your clinical trial was you can have 5 different types of chemotherapy followed by 1 transplant or 2 transplants followed by a bunch of other toxic therapy. And so what's happened, we've had just this rapid momentum and progression with our drugs. And so that combined with more education and better patient understanding, I think patients are seeing clinical trials as an option right? And it's a very feasible option. And it's possible that they're going to be getting very effective therapeutics that they may not have been getting 15 or 20 years ago. So, while it seems that, yes, we don't have enough clinical trials and things aren't moving fast enough, when you put it into the scope of where we've been in myeloma in the last 2 decades, things are moving at an extremely rapid pace. And we have, and that's 15 approvals. We have bispecifics, we have venetoclax, we have all these other drugs that are coming very quickly. And so we're making a lot of progress. And so I don't think that I see it as a very, I see it with rose lenses, right? Because I think that we're making a lot of progress.
Boy, oh boy, I'm going to go here. I'm going to start here.
Oh, thank you. When we talk about standard risk versus high risk, what's the criteria to be considered high risk? So, for example, a high LDH level can independently, I think, throw somebody into high risk versus the chromosomal abnormalities. So when we talk about the progression-free survival for high risk versus standard risk, what makes up that high risk population?
Now you're just trying to start a fight. There's nothing more contentious than this question in our meetings. And, nothing, literally people yelling at each other about how to define this. How high risk do you need to be for us to change our initial treatment to be multi-drug maintenance, et cetera? So I'm sure amongst the three of us, we don't agree. So one consideration, I'll throw out some things that I put in my high risk category that I had on my slides: the revised ISS stage 3, the extramedullary disease or disease outside the blood and bone marrow, patients who have greater than 5% circulating myeloma cells at diagnosis, patient and a number of, amplification of chromosome, of the long arm of chromosome 1 in patients with ISS stage 3, all these little details. And so I'm sure amongst us, we're not going to agree, but LDH is a component of the revised ISS stage, as it sounds like well, and it is one of the lab tests that we use that contributes to how difficult to treat patients' myeloma is.
And I agree completely. There's so much that we still don't know about risk, right? There's so many factors that contribute to risk. And our current risk stratification models, although they're getting better and better, but they're not perfect. So there are some patients who we classify as high risk, but they do as well as standard risk patients would do. And then there's some patients who we classify as standard risk, but they end up relapsing early, which goes to show that there's no perfect model that we have that accounts for all aspects of high risk. And yeah, so we're working on it. We're developing better systems. So I won't go into too much detail, but over the last year, we've had 2 new staging systems for myeloma come out. And the key advantage of these staging systems is that they account for some of the additive nature of these risk factors. So previously, stage 2 myeloma used to be this big heterogeneous group. Stage 1 and stage 3, yes, you'll be able to tell clearly, but stage 2 was just like the majority of patients fell in there, and some of them were more like very standard stage 1 type, and some were stage 3 type. But now we sort of have the granularity to sort of delineate that stage 2 myeloma further. So one of the newest staging systems, what we call the R2 ISS, or the second revision of the international staging system, that actually has 4 stages now, and that accounts for some of these cumulative risk features.
I mean, I don't think we're disagreeing. Yeah, I mean, I think we're all on the same page with this. I think that the only thing that I would add is that, the proof is in the pudding. And so, speaking to Monty's point, some of our standard risk patients actually have high risk disease, and they relapse or progress early. And so we are surprised by some, and it just speaks to the importance of continuing to monitor patients, keep our eyes on them, and just be aware that that's a possibility. And so, this just speaks to the importance of just ongoing care with your provider.
you.